I'm going to present the results of two studies that address the long-term safety and efficacy of Spravato and have been relatively recently reported. I'm a full-time employee of Janssen Research and Development and hold equity in Johnson & Johnson stock. Treatment-resistant depression, as we defined it, was basically the definition imposed by regulatory authorities of a patient that's shown non-response to at least 2 different antidepressants given an adequate dose and duration in the current episode of depression in a patient with major depressive disorder. Patients with treatment-resistant depression end up having a more severe clinical phenotype as manifest by greater disability rates, greater medical comorbidity, greater healthcare service utilization, and greater workplace absence than non-TRD patients. But they also have excess morbidity and mortality at any age in terms of excess the excess loss of life expectancy compared to MDD patients who are not TRD. They have a suicide attempt rate that's 2 to 7-fold times higher than MDD patients that aren't TRD. Among patients who are severely suicidal, about half are treatment resistant. And meta-analyses results have shown relatively high rates on a per 100-year basis of having completed suicides, attempted suicides, and as well as excess mortality. Treatment-resistant depressed patients also are less likely to respond when they receive new treatments. And so this is the STAR-D data exemplifying this, that patients, once they had failed the first 2 levels of treatment in STAR-D, the ones who did respond to levels 3 and 4 then both showed relatively low rates of response and remission. TRD patients also have less durable antidepressant effects. Here again exemplified by the STAR-D trial. These are the data from the 1-year follow-up in which patients remained on the treatment that initially they had responded to. And what you see is the patients who would qualify for the TRD criteria, these steps 3 and 4, because they had failed the first 2 levels, don't have very durable responses. They show a 50% relapse rate in just 3.3 months. And the relapse rate is 70% at about 10 months. In our esketamine nasal spray clinical development program for TRD, one of the focuses we had was on the durability of benefit for these patients who often have chronic or intermittent illnesses. In addition to the short-term pivotal trials that we ran, we also did a conventional maintenance of effect trial called SUSTAIN-1, a long-term open-label safety study called SUSTAIN-2, an even longer and larger one called SUSTAIN-3, which I'll present the results of today, and then a head-to-head trial against quetiapine used adjunctively with antidepressant that also had a maintenance phase, which I'll also present today. In general, the short-term studies showed that you would get a rapid antidepressant benefit. In these short-term studies, we always compared Spravato plus a newly added oral antidepressant against a newly added antidepressant plus placebo in the control arm. And this was a design that was mandated by FDA when we initially followed it. The treatment effect occurs rapidly within 24 hours, and then it's generally maintained across the 28-day period. In the maintenance studies, we used a combination of initially having a induction period where we would dose twice weekly for 4 weeks, and then moving to once weekly for 4 weeks, and then finally to after the 8th week, then patients could try every other week or weekly, and then we would individualize the treatment based upon whichever frequency could keep people well. This is a maintenance of effect study that used a classical randomized withdrawal design. Patients were randomized to either, they were stable responders on Spravato, and then were randomized to either continue Spravato plus placebo, or plus oral antidepressant rather, or to switch to a placebo nasal spray plus oral antidepressant. And you can see the relapse rate was significantly lower in the group that stayed on Spravato. In contrast, the group that was randomized to antidepressant alone ended up showing the very same relapse rate that I showed from STAR-D earlier, where by the third month, about half of the patients had relapsed. In the long-term open-label safety studies, where we followed this initial 4-week induction period and then followed by the optimization and maintenance phase, in general, the improvement persisted across the entire time frame. And we did a longer-term study that was initially intended to take patients from our other parent studies to allow them continued access to Spravato during the time we were waiting for it to be approved in the various countries in which they lived. In the course of this, FDA required us to continue the study for at least 3 years in each patient, and so the study ran at least 3 years, but some patients were in it as long as 6.5 years. Patients that entered this study, SUSTAIN-3, that had an interruption of treatment before they entered the phase 3 SUSTAIN-3 study, went through an induction phase again, where they had 4 weeks of twice weekly treatment. But the patients who entered, who were already responders, just entered directly into the maintenance phase. A total of 1,148 participants enrolled, of whom 1,110 received esketamine in the optimization and maintenance phase. The study involved 222 sites in 27 countries. The patients' age ranged from 18 to 93 years of age, and 122 of the patients were older than 65. 458 patients enrolled into the initial induction phase, and of these, 8% discontinued. The discontinuation was attributable to a lack of efficacy in 2% and adverse events in 1.5%. 420 of those patients then entered the optimization maintenance phase and joined 690 patients enrolled who were already responders, to make the 1,110 subjects treated in the maintenance phase. Within the maintenance phase, across this up to 6.5 year period, 38.7% discontinued. The other reasons were the most common, but this included some patients who felt better and didn't feel they needed the treatment anymore. It also included patients who moved out of area and it wasn't practical to continue the study. But it also included 6% of patients who discontinued due to an adverse event, and 4.7% of patients who discontinued due to loss of efficacy. This slide shows the duration of exposure during the study. The mean exposure was 42.9 months, the median about 45 months, and you can see that just over 60% continued for that 3-year period. There was a total of 3,777 cumulative patient years. During the study, the mode dose continued to be 84 milligrams, although you can see in the bottom, the bars in green are the group, so the mode dose was 84 milligrams, and just about 2/3 of patients received that. About 1/3 received 56 milligrams as their mode dose in the optimization maintenance phase, and 28 patients received just 28 milligrams, and these all were elderly, so that's 28 of the 122 elderly patients. The lower panel shows the frequency, the dosing frequency, and the mode frequency continued to be weekly for the majority of patients. But the green bars show the group that was able to get by with just every 4-week treatment, once every 4-week treatments, and you can see that this group continues to increase as the study advanced. During the initial induction phase, the mean MADRS score decreased from 29 at the baseline to 16 at the induction endpoint, with a mean change of about 12.8, and 35.6% of the patients achieved remission. As the reduction in MADRS scores generally persisted during the rest of the study. These are the data from the optimization maintenance phase, and by week 8 in this phase, about 50% were in remission, and at the end point at 296 weeks, it was also about 50% in remission, and during the study, the remission rate hovered around that 50% mark. During the study, a total of 94.9% developed a treatment emergent adverse event. In about 75% of the subjects, that treatment emergent event was thought to be at least possibly related to esketamine. We had 9 deaths total, and 18.8% of patients experienced a serious adverse event. The number of subjects that discontinued treatment due to an adverse event amounted to 6.3% of the sample. Most of the common adverse events were adverse events such as headache, nausea, dizziness, dissociation, somnolence, and dysgeusia that were transient and ended up lasting about 2 hours after the infusion. Most of the adverse events that occurred also occurred on the dosing day for esketamine and then resolved the same day. Of the serious adverse events that occurred, most involved elevations of blood pressure or dissociation or dizziness, severe dizziness, but in the SAEs that involved an exacerbation of the underlying illness that occurred in at least 1% of patients are listed here, as a worsening of depression occurred in 1.6%, 1.3% made a suicide attempt, and suicide ideation was present in 1%. Of the 9 deaths that occurred, none was considered by the site investigator to be related to esketamine, and one was a completed suicide, one was a myocardial infarction that occurred 6 days after the most recent dose, one was multiple injuries from a bike accident where they were hit by a car that occurred also 6 days after the most recent dose. Two were due to pneumonia, 3 due to COVID-19. And the mortality rates and suicide attempt and completion rates are on a per 100 patient year basis are listed in the middle column for the SUSTAIN-3 data. And in general, these are much lower than what you'd expect based upon the literature rates for treatment-resistant depression. So the suicide attempt rate per 100 years was 0.42 for SUSTAIN-3, but over 10 times higher in literature reported rate. The completed suicide rate was 0.026 per 100 patient years, but this is also lower than the range reported in the literature of 0.14 to 0.47. The all-cause mortality rate in SUSTAIN 3 was 0.24, but this was also a lower rate than the 0.79 to 4.6 range reported in the literature from meta-analyses of TRD patients. In conclusion, SUSTAIN 3 showed that in general, the antidepressant efficacy of esketamine is sustained if you keep dosing it on a pulse basis, and only 5.3% ended up dropping out due to lack of efficacy. There were no new or unexpected safety findings, as opposed to those that had already been identified in shorter-term trials. The cognition remained stable as measured by the Cogstate test battery. There were no changes in memory or verbal processing. There was a slight slowing of reaction time seen in the elderly patients, but this was a nonspecific finding attributable to the just greater variability. And this has been shown in other studies that were long-term studies of depressed patients that were elderly who were treated with antidepressant drugs. There was no evidence of interstitial or ulcerative cystitis that had been reported in abusers of ketamine. There was also no case of respiratory depression, renal or hepatic adverse events, abuse, dependence, or withdrawal symptoms. Although there were deaths and one suicide among the deaths, the rates were relatively low compared to what was to be expected for the TRD population. The second study I wanted to show is also with data showing long-term effects was known by ESCAPE-TRD. ESCAPE-TRD was a randomized, open-label, rater-blind phase 3b trial that compared the efficacy and safety of esketamine nasal spray with quetiapine XR, both flexibly dosed and used adjunctively to an SSRI or SNRI antidepressant in patients who had treatment-resistant depression and who also had experienced minimal improvement on their SSRI or SNRI. This was the first study in which we looked at both the acute and the maintenance of phase in the same study against an active comparator. Both Spravato and quetiapine XR are approved in multiple countries for the treatment of MDD, but we used quetiapine partly because it was the only adjunctive therapy for depression that was approved in Europe. And one of the main reasons that we needed this study was to gain access with payers in Europe. The design of the study is shown here. 666 patients were randomized to either flexibly dosed open-label esketamine with continuing SSRI, SNRI antidepressant, or to flexibly dosed open-label quetiapine XR with continuing SSRI or SNRI. The primary endpoint was a remission at week 8, which was the end of the acute phase, and the key secondary was the proportion of patients who had been in remission at week 8 and then did not relapse through the end of week 32, which was the end of the maintenance phase. Esketamine was dosed as we have in other studies, where in the first 4 weeks it's twice daily, and then for the next 4 weeks it's once weekly, and then in the subsequent weeks of the maintenance phase, patients can receive it either weekly or bi-weekly. In contrast, the quetiapine was dosed on a daily basis, and the visits were weekly in the first 4 weeks, and then bi-weekly in the subsequent visits. The primary outcome was positive, with esketamine the esketamine arm showing a greater remission rate than the quetiapine arm at the end of the acute phase, week 8, with 27% of patients having remitted in the esketamine arm and 6.6% in the quetiapine arm. This significant effect was true, though, for all the time points measured beginning at week 6, where I'm sorry, I just lost the pointer. Where you had significant effects through the remainder of the study in terms of the remission rate being higher in the esketamine group. At the end point, there were 55% of the Spravato group in remission and only 37% of the, compared to 37% of the quetiapine group. The secondary endpoint was also positive. The proportion of patients who were in remission at week 8 who remained relapse-free through week 32 was 21.7% in the esketamine arm and 14% in the quetiapine arm. The proportions who achieved response essentially were similar to those to the remission data, where you had higher rates across the time period for the beginning at week 2. The p-value was less than 0.001 for the separation in response rates between the esketamine arm and the quetiapine arm. You also saw in the mean MADRS scores, the change across time was a little more prominent during the early going with in the esketamine group, but maintained the greater benefit across the entire study. The discontinuation rate was actually higher in the quetiapine arm than in the esketamine arm. 11% of the patients in the quetiapine arm discontinued due to a treatment-emergent adverse event, with the most common reasons being sedation, somnolence, weight gain, or fatigue. The discontinuation due to treatment-emergent adverse events for the esketamine arm was 4.2%, with the most common reasons being dizziness, dissociation, or vomiting. In summary, the long-term maintenance of the antidepressant effect with Spravato was shown in this study as well, in this case compared to an active comparator. But in general, the use of pulsed esketamine across time appears to maintain the antidepressant benefit within patients who had treatment-resistant depression. In this last study, I should mention there were no deaths and no suicides in the last. There was one patient in each arm attempted suicide, but there were no completion of suicide or deaths. And then lastly, I've got the obligatory prescribing information to just flash up, but you know. So let me stop there and take questions.
Thanks for sharing such interesting data. We've got time for a couple of questions. Okay, Alan, you go.
No, Wayne, those were two nice big studies, but the question I have is, did you follow the people after they had actually stopped or gotten off? Because that was the issue when the drug came up for approval at the FDA, that there were these people who came off the open label who became more suicidal when they had to stop it. Did you do any of that kind of follow-up to see?
Yeah, we did. Yeah, in the patients that were at the end of the study, we did follow up, and we also looked for evidence of withdrawal symptoms, and did not see any evidence of withdrawal symptoms. The data for this are actually published. The ESCAPE-TRD data are published in the New England Journal of Medicine. Andreas Reif was the first author, but the data for the withdrawal phase is actually published there for the two compounds. It looked like you had, maybe more withdrawal from the quetiapine, perhaps because of the antihistamine effects, than what you did in the esketamine arm.
I wonder, ESCAPE TRD study, it included patients with a single episode and also with no necessity of de novo backbone antidepressants. So it was continuation of backbone antidepressant and esketamine came afterwards. Could you comment on any kind of lessons learned from that kind of trial design that is very much distinct from the previous study? To my best knowledge, this is the first one that included such patients.
Yes. I mean, you're right. There were some differences in the entrance criteria between the two. One of the differences was that in the ESCAPE TRD study, it was required that patients have at least a minimal benefit from the antidepressant, as opposed to no benefit. So that was one of the differences. And in addition, they were patients that would benefit from adjunctive therapy, and so would qualify for the quetiapine label. I think a clear limitation of that study design was the open label nature, but although the raters were blind, patients and the clinicians were not blind, and so that was a clear limitation.
Yeah, thank you very much for your interesting talk. In the Netherlands, in our open label program, there are some patients that report on sexual dysfunction. I was wondering if you've monitored on sexual dysfunction as well.
I'm sorry, I couldn't hear your question.
We have some patients in the Netherlands that mention sexual dysfunction during ketamine treatment, and I was wondering if you've monitored or if you've assessed any questionnaires on sexual dysfunction as well.
Yeah, we did look for new cases, incident cases of sexual dysfunction based upon treatment-emergent adverse events. But since all of the patients were also on an SSRI or SNRI that do have sexual dysfunction, Spravato there was a level of sexual dysfunction that was present that was not abated by the esketamine treatment.
Thank you, Wayne.
Rupert?
Oh.
Yeah.
Sorry, go at the back.
Oh.
Sorry, just two quick questions. Curious about the frequency during the maintenance phase for the first trial. I'm wondering, was there standardized criteria for trying to space out the frequency of esketamine administration during maintenance? And then a follow-up question is just sort of how you imagine the overall trajectory of esketamine treatment. Do you see this being something that's, indefinitely once a week for treatment-resistant depression?
Yeah, those are great questions. So we did have sort of standardized criteria for the clinical sites to make the decision about when they did move from once a week to once every 2 weeks, when to know to shorten back up the frequency. And we also did not test other frequencies. Within the SUSTAIN 3, we tested up to once a week, once every 2 weeks, or once every 4 weeks. But we did not test sort of gradations between there, which does happen more in the real world now that Spravato is available. In terms of the long term, you raise a great question. These are patients that typically haven't gotten better with other things, and the patients who have, there are patients who dropped out because they felt like they were either doing well enough they didn't need to continue the treatment, or their episode wasn't recurring as their symptoms weren't recurring by the end of the episode, or by the end of the interdose interval rather. And so we did have some patients that dropped out just because they felt they were doing better. But you still had a sizable sample that had not done well with anything else and previously. And then the question is how will they be managed in the future? One of the things that we're doing at Janssen is trying to develop follow-ons to esketamine that will be something you could take at home that won't have the abuse liability or some of the safety concerns like blood pressure that esketamine had. but we haven't succeeded at something that's on the near horizon to replace esketamine for those patients yet.
Okay, I think we ought to move on, but let's thank Wayne again for that.
Thanks.